Hi, everybody. Welcome to our second presentation in our mechanical ventilation series. So in this presentation, we're going to cover a couple of special cases. So hopefully after the first presentation, you're feeling a bit more comfortable with the basics of mechanical ventilation and the parameters and settings that we need to be prepared to choose. Unfortunately, not all of our patients are going to be as straightforward as the example that we used in the last case. Some of them have physiology specific to their disease, which requires a bit of a more nuanced approach. And we can't cover all the examples here, but I've picked a couple of the higher yield ones that we'll probably encounter more frequently. And so these are going to be acute respiratory distress syndrome and obstructive pulmonary disease, which will most commonly be COPD and asthma. And in both of these cases, a little bit of extra knowledge and how to tailor our approach to these disease processes and their physiology can make a pretty big difference for the care of our patients. So we'll go ahead and talk about our objectives for this session. So there's four of them, and the first two relate to ARDS and second two relate to COPD. So by the end of this session, I'd like you to be able to choose ventilator settings consistent with a lung protective strategy for an ARDS patient. And then I'd also like you to be able to adjust those settings to correct for hypercapnia as well as elevated plateau pressures in an ARDS patient. For obstructive patients, the goal would be for you to choose ventilator settings to minimize risk of breath stacking in an obstructive patient, and then to be able to assess this patient while they're being ventilated and adjust as necessary for breath stacking. So let's start with acute respiratory distress syndrome. So ARDS. So we're all very familiar with this from medical school and from residency as well, but we'll just do a brief review. So this is a state where you have an injury to the lung. There's an inflammatory state which can cause increased pulmonary, vascular, and epithelial permeability, pulmonary edema, atelectasis. These patients have severe lung injury in many cases, and they're going to be difficult to oxygenate often. In this case, the injured lung kind of behaves like a smaller lung, meaning that they cannot tolerate the same tidal volumes that they would if the same patient's lungs were in a healthy state. And ventilating injured lungs with tidal volumes the patient could normally handle can actually lead to barotrauma and worsened lung injury and even lead to increased mortality in these patients. And with a few pretty simple changes to our strategy, we can reduce the risk of further damage and give these patients the best chance possible. So first, we'll talk about oxygenation in an ARDS patient. And so like I already mentioned, these patients have a lung injury that can cause severe hypoxia. And these patients, bear in mind, they may be challenging to oxygenate despite your very best efforts and the most optimal ventilatory care. So just as with our patients without pulmonary disease, when you have newly intubated this patient, it's probably going to be a good idea to oxygenate them with 100% FiO2 for at least a few minutes in that immediate post-intubation period. And again, this is going to be because they've been apneic for the duration of the intubation. They're probably a bit hypoxic from it, and they were probably not starting with a lot of reserve to begin with anyways. After this, we can begin to slowly titrate down our FiO2 and PEEP based on their oxygenation. And we'll talk about both of these a little bit more in just a moment. So for these patients, our goal is not going to be 100% saturation. It's probably going to be more in the range of 88 to 95%. And if we have them saturating there, we'll be happy. And so there's a pretty good guide for how to titrate your PEEP and FiO2. And you may have heard of something called the ARDS network, sometimes called ARDSnet. And this is a research network that has produced a number of valuable studies related to care of ARDS patients. And one thing that has come out of their research is an FiO2 PEEP table. And this is the table that that you see on this screen here. And this is a guide that can help you titrate your oxygenation parameters. So as you can see, it's a stepwise approach that's going to pair an FiO2 with a PEEP. So you can see, if you can see my pointer on the screen, if you started with this first, which is the lower PEEP, higher FiO2, you'd be starting this patient at a PEEP of 5 and an FiO2 of, this is 30%. And then increasing in this stepwise fashion. So if your patient is still not oxygenating in a satisfactory way, you would then increase your FiO2 next to 40%, keeping your PEEP the same. The next step would be to increase your PEEP, keeping your FiO2 the same, and so on. And of course, you don't, if your patient is not oxygenating well at 100% FiO2 and a high PEEP immediately after intubation, you're not going to drop them all the way down to here and start. But this is just a guide that you can use. And if you are down here and they're having increasing trouble oxygenating, you can use this to titrate your way up. But you, of course, want to use your clinical judgment. And the original paper that discusses this research and table is listed as the first reference to this particular presentation. And if you haven't read it before, you may have because it's fairly well known. I recommend taking a look at it. It's not a long paper, it's not a difficult read, and it is pretty helpful. So in some ARDS patients, their lungs might be so injured that despite going up relatively high on your FiO2 and PEEP, you're going to still have difficulty oxygenating them. And there are a couple other techniques that we can use here, like inverted I to E ratios and airway pressure release ventilation, known as APRV, which you can utilize too. And so we're going to talk about both of these techniques, but in order to make sense of them, it's pretty helpful to understand a concept known as mean airway pressure. And so there are two primary factors that affect a patient's oxygenation. And those are FiO2, which we're all familiar with, and mean airway pressure. And what mean airway pressure is it's a representation of the average pressure that is going to be experienced by the alveoli over a ventilatory cycle. And so this is a figure that I found, which I think illustrates this really well. And you can see it's a plot of pressure versus time for a ventilated patient. And the shaded blue area is going to be the pressure experienced during the ventilatory cycle. And you can see this PEEP that the patient is set at is kind of the baseline level. And then during inspiration, you go up to a peak inspiratory pressure. And you can see that, as the breath is there, and then it drops back down, and then you have your expiratory time. And as you can imagine, there's going to be several ways that you can influence your mean airway pressure, which is essentially the integral of pressure and time under. So the blue shaded area here. And we tend to think of PEEP as being a parameter that affects oxygenation, and it does. But what you're really doing by increasing PEEP is you're increasing the baseline here, which is going to increase the mean airway pressure. And that's ultimately what you're doing. So the next couple slides are going to cover techniques by which we can increase this mean airway pressure. So the first one that we'll talk about here is an inverse I to E ratio. So under normal physiologic circumstances, we spend about twice as much time on expiration as we do on inspiration. This ratio can be inverted though, and this can benefit our oxygenation. So you can invert ratios to 2 to 1, 3 to 1, or even greater in some cases. And it's fairly easy to see how this increases your mean airway pressure and subsequently oxygenation. So like we said on the previous slide, the blue part of the graph here, if you took that area, that is your mean airway pressure. So in this first one, you can see we're spending more time on expiration than we are on inspiration. If we were to invert that ratio, like in this second picture over here, now we're spending more time on our inspiration than expiration. And you can see that this blue area has pretty significantly increased. So this is going to improve our oxygenation. A second technique that we can use is called airway pressure release ventilation. And this is another technique that increases mean airway pressure to improve oxygenation. And in a sense, this kind of takes your I to E ratio inversion just to an extreme. So you're basically applying a high continuous pressure with brief releases down to low pressure, which is going to be kind of like your PEEP in this scenario, so that a significantly higher fraction of your ventilatory cycle is spent at higher pressure. So sometimes patients are going to have difficulty tolerating these high pressures throughout much of the respiratory cycle, and APRV allows them to breathe spontaneously over the cycle. And you can see over here where you see like these small dips and the one circled in red, that's to represent the small breaths that the patient is taking over top. And it's keeping the pressure high, but it's allowing them a little bit of extra comfort here. And so when you're placing a patient on APRV, you set your CPAP and then you also set your PEEP. And the higher the CPAP, like the longer amount of time that you're spending up at that higher pressure, the better your oxygenation is likely to be. These techniques come at a cost, though. More time spent on inspiration means that you're doing less ventilation, and this can potentially lead to hypercapnia. Another problem here is that you are dealing with higher pressures on average in the thorax, and this can have consequences on your hemodynamics. The higher intrathoracic pressure can reduce your preload and subsequently your cardiac output. So this is something to keep in mind because if you have a patient whose hemodynamic status is already tenuous, you may need to resuscitate them more in that respect before attempting some of these situations, which are going to be using higher PEEP or inverse ratios or APRV. So now we'll talk about ventilation for an ARDS patient. So this is what we think of as lung protection for these patients. And like we said earlier, we're aiming for lower tidal volumes here. You have less workable lung volume in these patients in their injured state than they do in their healthy state. So we're going to be targeting somewhere in the range of 6 to 8 milliliters per kilogram of ideal body weight. And this is another study that I just have referenced here on the screen from the ARDS network, which was the one that demonstrated better better outcomes using these lower tidal volumes compared to traditional. And so this equation on the right-hand side of the screen is just reminding us what minute ventilation is, and that's your respiratory rate multiplied by your tidal volume. Since we're ventilating these patients with lower than normal tidal volumes, we're likely going to have to use a higher respiratory rate to keep their PCO2 in an acceptable range. And even then, you are probably going to have to tolerate some degree of hypercapnia. You could start at a rate of probably 16 to 18, which is higher than we were going for with the patient we discussed in the last presentation. And then you can adjust from there based on your gases. And so we'll talk a little bit more about um, our ventilator adjustments here. So let's say you're ventilating your ARDS patient and you wonder to yourself, am I protecting this patient's lungs appropriately? So you're going for that somewhere in that like 6 to 8 milliliter per kilogram tidal volume. And you're wondering if you're adequately protecting their lungs. And there's a fairly simple way that you can check this, and this is by checking a plateau pressure. So the graphic on this slide shows a pressure waveform during a breath delivered by a ventilator. The plateau pressure is the pressure after this peak here and during what's called an inspiratory hold. And this can be used as a surrogate for the pressure that the alveoli are experiencing. Generally speaking, if your plateau pressure is less than 30, you can be pretty confident that you are protecting your patient's lungs. If you're up over 30, you may not be in that protective range, and it's worth considering decreasing the tidal volume a bit more. So now let's talk about another complication we mentioned, which is hypercapnia. So let's say you're ventilating a patient with ARDS. The VBG that you got prior to intubation shows that you have a PCO2 of 50. And now, so 30 minutes post-intubation, you repeat a VBG and you have a PCO2 of 60 and a worsening acidosis. So what can you do? We can't really increase the tidal volume too much without risk of worsening the patient's lung injury through barotrauma. But what we can do is increase their respiratory rate. And again, you still probably will not be able to fully compensate despite increasing respiratory rate. And you're probably going to have to accept some degree of hypercapnia. Fortunately, though, most patients tolerate a degree of respiratory acidosis fairly well. And there's a number of newer studies showing that permissive hypercapnia may have some detrimental effects, particularly relating to pulmonary vascular resistance and right ventricular function. And I've listed a couple of these resources in the references here. However, you're dealing with a patient that doesn't give you many options, and you're probably going to have to accept that hypercapnia rather than giving barotrauma and kind of spiraling the patient into more and more injured lungs. So a couple of key takeaways for ventilating our patient with ARDS. So you will probably need a high PEEP and FiO2. You can use that PEEP table from the ARDS network to help you titrate that. If you're still having difficulty oxygenating this patient, inverted ratio ventilation, or APRV, may be options to consider. And then lastly, remember that low tidal volume in that 6 to 8 ml per kg range and plateau pressures less than 30 are how we try to protect our patients' lungs while ventilating them in this injured state. So now we'll move on to obstructive disease. So the two forms of obstructive disease that we probably encounter most are COPD and asthma. And these are diseases that are quite familiar to us. So as you know, they're distinct diseases, but both result in obstructive pattern. So in asthma, the airway structure itself is normal and the obstruction is reversible. In COPD, the airways are damaged and the obstruction is really, it's just less reversible than it is with asthma. Despite these distinctions, for the purpose of ventilating these patients, there's really pretty significant overlap here. The obstructive nature of both of these diseases leaves patients prone to something called autopeep or breath stacking. And breath stacking occurs when a new breath is inspired before full expiration of the previous breath. And what happens here is that over time, if you're breath stacking, you can eventually lead to enough air being trapped in the lungs that you get progressively increasing intrathoracic pressure. And eventually that pressure can reach levels where it begins affecting preload and hemodynamics, or even causing barotrauma and potentially a pneumothorax for a patient. And both of these, of course, can be potentially deadly consequences for a patient. But once again, we can reduce our risk of these complications by adjusting our strategy just a bit. So first, we'll talk about oxygenation for this patient. So again, we're going to be setting our PEEP and our FiO2. And in this patient, we can set our initial PEEP fairly low because this patient is already giving themselves some auto PEEP in their lungs. We can probably go 5. Some sources will say you could go even lower than that. And then for FiO2, there's not really a hard or fast rule here. We're just going to titrate our FiO2 to meet our oxygenation goal. And again, probably in the like high 80s, low to mid 90s. And then for ventilation, just like ARDS, ventilation in these patients is key. However, this time, instead of tidal volume being our lung protective feature, it's going to be the amount of expiratory time and the amount of exhalation that we allow patients. Since our tidal volume is a little bit less critical, you can go a little bit higher than we did on the ARDS patients, and maybe 8 milliliters per kilogram of ideal body weight is a good place to start. And then to maximize our expiratory time, we want to choose a low respiratory rate, which is going to give the patient that additional time to fully exhale the breath. So we could start with a respiratory rate maybe around 10, and then we could set an I to E ratio. So like we said, normal physiology is 1 to 2, and some of these patients you could go even up to 1 to 4 or 1 to 5 to give the patient a really generous amount of time to expire before the next breath is pushed in. So how do we monitor for breath stacking? So let's say that you've intubated a patient with a severe COPD exacerbation, and you've done your very best to give them as much time as possible to expire. How can you know if your strategy is working? And there's a couple of ways to check. So one way that you can check is to test a plateau pressure. And just like we talked about for ARDS, so you would do an inspiratory hold or an inspiratory pause and check the pressure. And a pressure under 30 is again reassuring that the patient is not breath stacking and increasing that intrathoracic pressure. Another way that you can do it is look at the flow waveform on the ventilator. And the graphic that we have on this slide here is really, I think, a helpful illustration. So images C and D represent a patient who is not breath stacking. So image C, the part of the waveform above the horizontal axis shows inspiration, and the part below shows expiration. And you can see that the flow is going to return to zero, which is the horizontal axis, before the next breath is inspired. Figure D shows the lung volume of the same patient over time. And here you can see that the volume increases with each breath, but returns to baseline after each expiration. Now, figures A and B represent breath stacking. And on the flow waveform, you can see that the expiratory part of the wave does not return to zero before the next breath is pushed in. Consequently, you can see on the volume plot that the volume keeps increasing with each respiratory cycle. And this is because after each breath, you haven't fully gotten the volume of the previous breath out, and the next one just stacks on top of it, and that keeps building on each other. If you see evidence of breath stacking, consider reducing the respiratory rate a bit more, because we want to give that patient even more time to exhale. So what are our conclusions for obstructive disease? So we want to give our patients a lower respiratory rate and plenty of time to exhale. And so this is, like I said, low respiratory rate and then a longer expiratory time. And then monitor your patient for breath stacking. A quick and easy way to do is to look at the flow or volume tracing, which is pretty easy to see on the ventilator. And then usually the flow is what's displayed. And then if you have a concern, you could easily check a plateau pressure. And then if it looks like you are in fact breath stacking, or your patient is rather, go ahead and reduce the respiratory rate or increase the expiratory part of the I to E ratio to give that patient even a bit more time. So for our overall conclusion, so ARDS and obstructive lung disease are a couple of the more common special cases that we will encounter for mechanically ventilated patients. And with pretty simple adjustments, we can adjust our strategy to maximize our patients' chances of recovering their health and having a good outcome. Some of these patients are really sick, and despite doing our absolute best, we still may not be able to meet their needs, but we can do our best with this approach to give them the best chance possible. Here's a list of the references that I used creating this presentation, and a lot of them are pretty easy reads, and I really highly recommend checking them out if you want to go a little bit deeper into this topic. I hope you found that helpful, and I'll see you in the next presentation.